At approximately 6 weeks gestational age, the fetal pole, or embryo, develops cardiac activity, which appears as flickering within the fetal pole and is now considered a live intrauterine pregnancy. Any embryo measuring more than 5 millimeters must have identifiable cardiac activity on endovaginal ultrasound to be considered viable. As the embryo continues to grow, about 1 millimeter each day, the yolk sac will shrink and the amniotic sac will grow outwards towards the gestational sac. This endovaginal ultrasound shows an empty uterus and a right-sided adnexal mass that demonstrates the ring of fire sign with power Doppler imaging. The presence of this extrauterine gestational sac, which contains a yolk sac, is a definitive sign of an ectopic pregnancy. In this endovaginal ultrasound examination, one sees the bladder, the uterus, and an intrauterine pregnancy. However, adjacent to the intrauterine pregnancy is an artifact from an intrauterine device. On pelvic ultrasound, there are several reliable sonographic signs of an abnormal intrauterine pregnancy or embryonic demise. The earliest sign of embryonic demise is a large empty gestational sac. Another reliable sign of an abnormal IUP is a large fetal pole without cardiac activity. If a fetal pole has a crumb rump length greater than or equal to 5 millimeters and does not have cardiac activity, the intrauterine pregnancy is abnormal. This endovaginal ultrasound reveals a fetal pole with a crumb rump length of at least 5 millimeters lying within the gestational sac. However, the absence of cardiac activity indicates that this is an abnormal IUP. This pelvic ultrasound reveals a uterus containing a gestational sac, amnion, a yolk sac, and an adjacent fetal pole. Slowly fanning through the fetus does not reveal any cardiac activity. Since the fetal pole measures much larger than 5 millimeters in crown rump length, this is an abnormal IUP. This endovaginal ultrasound reveals a live intrauterine pregnancy. The gestational sac is at least 5 millimeters in internal diameter and has a thick concentric echogenic ring and lies within the uterus. The IUP is alive because the gestational sac contains a fetal pole with cardiac activity. The 3 ultrasound images, 2 endovaginal on the left and 1 transabdominal on the right, all reveal the same findings: an intrauterine mass composed of multiple, diffuse, irregular, hypoechoic vesicles or grape-like clusters. These classic findings are consistent with gestational trophoblastic disease or a molar pregnancy. In this endovaginal ultrasound performed on a patient with a positive pregnancy test, the uterus is empty and the right adnexa contains a concentric hypertrophic structure. This ring-like structure, also known as a tubal ring, has a bright, echogenic, round, and symmetric wall, thereby differentiating it from a corpus luteum or other ovarian cyst.
The embryo can be recognized by high-resolution transvaginal ultrasound at 2 to 3 millimeters in size, but cardiac activity will be consistently seen when the embryo reaches 7 millimeters in length or greater. First cardiac activity should be seen at 6 to 6.5 weeks. The appearance of cardiac activity, which appears as flickering within the fetal pole, constitutes a live intrauterine pregnancy. The ampullary and isthmic sections of the fallopian tube account for the largest proportion of ectopic pregnancies. In this transvaginal ultrasound clip of the right adnexa, a normal ovary is seen and identified by the presence of multiple small follicles. Note the anatomic location of the ovary overlying the internal iliac or hypogastric vessels. As the ultrasound transvaginal probe is moved into the medial aspect of the right adnexa, an ectopic pregnancy is seen in the ampullary segment of the fallopian tube. Note that the ectopic pregnancy is round and more echogenic than the adjacent ovary. When detecting an embryonic or fetal heartbeat with a diagnostic ultrasound system, the AIUM recommends initially using M mode because this transvaginal ultrasound clip represents a sagittal sweep of the pelvis, showing the uterus in mid-sagittal view and a significant amount of free fluid in the posterior cul-de-sac and surrounding the uterus. The endometrium is also shown during the sweep and appears normal. A blood clot is shown in the posterior cul-de-sac towards the end of the clip. The pelvic fluid in this case was related to intra-abdominal bleeding from a ruptured ectopic pregnancy. When measuring the CRL, the operator should use the mean of 3 discrete measurements obtained in a mid-sagittal plane. The CRL increases rapidly at a rate of approximately 1 millimeter per day. In pregnancies less than 9 weeks gestation, a discrepancy between menstrual or gestational age and sonographic age of more than 5 days from last menstrual period is an appropriate reason for changing the expected date of delivery, or EDD. For pregnancies between 9 and 13 and 6/7 weeks gestation, a discrepancy of more than 7 days should result in a change in the expected date of delivery. This ultrasound clip shows a sagittal view of a uterus with a gestational sac and a large subchorionic bleed. Note that the blood clot is of significant size and fills almost the entire uterine cavity. In this case, no embryonic cardiac activity could be demonstrated. This large subchorionic hemorrhage resulted in a failed pregnancy. Fetal breathing movements are defined as one or more episodes of rhythmic fetal breathing movements of 30 seconds or more within a 30-minute period. The presence of normal fetal breathing movements makes fetal acidemia with a pH of less than 7.2 unlikely. Fetal movements are defined as 3 or more discrete trunk movements within a 30-minute period. Fetal tone is defined as one or more episodes of extension with return to flexion of a fetal extremity or opening or closing of a hand within a 30-minute period. Adequate amniotic fluid volume is defined by an MVP of amniotic fluid of greater than 2 centimeters. Amniotic fluid measurements should only be taken in cord loop-free pockets of amniotic fluid. As noted earlier, the biophysical profile is performed with real-time ultrasound over a period of 30 minutes. Each of the 5 components of the biophysical profile is scored as 2 when present and 0 when absent. The score is thus added, and a normal biophysical profile is defined by a score of 10 or 8. A score of the fetal heart can often be seen as a 4-chambered structure by 13 to 15 weeks gestation, and by 16 weeks gestation, all 4 cardiac chambers should be clearly evident. The chamber walls should have a hyperechoic appearance, which contrasts with the anechoic appearance of blood within the chambers. The chambers are typically relatively symmetric in size and are separated by bright hyperechoic atrial and interventricular septate. The fetal spine and thoracic ribs assist with orientation and help identify the anterior-posterior axis of the thorax. The cardiac axis is defined by the angle of the interventricular septum with respect to the anterior-posterior diameter of the thorax. The normal cardiac axis is 45 plus or minus 20 degrees. The heart is normally common chest lesions include diaphragmatic hernia, cystic and hyperechoic lesions of the lung, such as congenital cystic adenomatoid malformation, extralobar sequestration, and congenital hydrothorax and pleural effusions. Congenital hydrothorax and pleural effusions may be an isolated finding or may be associated with anasarca. In both instances, if the pleural fluid collection is large enough, lung compression with resultant pulmonary hypoplasia may result. Sonographic characteristics of pleural effusion include an anechoic fluid collection within the thoracic cavity surrounding the lungs and often outlining the heart. Head circumference measurement often follows biparietal diameter measurement. This approach allows the operator to utilize the same relative imaging plane and caliper positions used for biparietal diameter measurement, which expedites the process. If a biparietal diameter image is used to measure head circumference, one must ensure that the plane of section was perpendicular to and included the thalami, third ventricle, and cavum septi pellucidum. Importantly, a subtle adjustment to one of the caliper positions used for biparietal diameter measurement is required for measuring head circumference. The lower, more distal caliper icon used to measure biparietal diameter should be moved to the outer bony edge of the parietal skull. If the umbilical cord or umbilical vessels appear tethered to the membranes at the level of the internal os or in the lower uterine segment along the cervix, vasa previa should also be diagnosed. It is important to rule out a phonic or cord presentation. A phonic presentation is a type of fetal presentation that is diagnosed when the umbilical cord is the leading presenting part of pregnancy. It can be diagnosed by asking the patient to move around and seeing if the umbilical cord moves in the process. Repeating the transvaginal ultrasound examination at a later date and determining whether the umbilical cord maintains a fixed position will also help confirm a phonic presentation. The location of the umbilical cord segment will move with a phonic presentation, while the location of the cord segment will not change in vasa previa.
chose